It is a huge honor for me to be podcast interviewing a legend in dentistry, Gregori Kurtzman. Greg, seriously, I mean, I don't know. I don't think I know anybody who's been published 450 times, has 1,000 posts on Dental Town. You are a legend to so many. Let me read your bio just in case you didn't catch one of his 450 published articles. Dr. Gregori Kurtzman is in private general practice in Silver Springs, Maryland, and a former assistant clinical professor of University of Maryland, which is the first dental school in America, and a former AAID Implant Maxi-Course assistant program director at Howard University College of Dentistry. I just love the name of that dental school, Howard University. He has lectured internationally on the topics of restorative dentistry, endodontics and implant surgery and prosthetics, removable and fixed prosto, perio, and has over 450 published articles. He has earned fellowship in the AGD, the AAIP, ACD, ICOI, Pierre Fauchard, ADIA, Mastership in the AGD and ICOI, and Diplomat status in the ICOI, and American Dental Implant Association. Dr. Kurtzman has been honored to be included in the top leaders in continuing education by Dentistry Today annually since 2006 and was featured on their June 2012 cover. You put up a Dental Town, one of the most legendary Dental Town courses on core buildups, post and core, understanding the ferrule, which I still don't think half the dentists in the United States understand. You always see them with these flat preps, and they try to think they're going to get everything with a big post buildup. But
no, they don't even want to use posts in those cases. That's the problem.
I mean, my God, you could lecture for 40 days and 40 nights and still educate me on A to Z. Thank you for joining me today, Greg. How are you doing?
My pleasure. Great day today.
And
it's beautiful weather. It's not snowing anymore. I'm happy.
Is it finally warming up there? What is this? The 7th now, February 7th. This is actually Super Bowl Sunday. Are you going to watch the game?
My girlfriend will force me to watch it, I'm sure.
Yeah, I'm a embarrassingly NFL addict, and I know it's crazy, but it's just my little thing that I allow myself to indulge in. So what did you want to talk about today? Did you want to I've seen you've been talking a lot about well, you could review your Dental Town CE course at the beginning if you wanted to, or the end, but I know that you've been doing a lot of research linking oral biofilm, formerly referred to as plaque, with systemic conditions such as cardiac disease, diabetes, pulmonary disease. It seems like you've really been interested in perio a lot lately.
Well, I think it's really the link that attaches a lot of stuff, and it really makes or breaks what we're doing in dentistry. And, they're finding over the last 10 years that there's a big link between perio biofilm, what we used to call plaque, and systemic issues like you touched on. So I think that everything is finally coming together, how the mouth is really interconnected. I'm not sure. You probably graduated dental school about the same time I did. I graduated in 86.
I was 87.
And we were still, we were like sort of still tooth mechanics back then. They really, you didn't go past the back of the throat. You didn't concern yourself pretty much with anything in the body. Now we're finding there is a big connection there.
Well, even in 2016, you go to a bar and you're sitting there with 5 dentists watching sports, eating a cheeseburger, and they still talk about dentistry like they're mechanical engineers. They always talk about the wear rates of fillings, but I don't see my fillings wearing down. They always talk about adhesive bonding strings. My problem's not my fillings falling out. We're biologists. We build barns and they're eaten by termites, and it's all about biology and oral. We're physicians of the mouth. We're not mechanics.
Oh, absolutely. I agree with you. And it's the bone and the gums that hold everything in, whether it's natural teeth or implants. And if you don't preserve that, if you can't and the patient can't, doesn't matter how beautiful that filling is, how great that crown is, it still fails.
Well, when you're reading this research and we're reading it, and I mean, obviously, 1,000 years from now, almost everything we know now is going to look silly. I mean, one of the most exciting things I ever did was about the first 3 books autographed and signed by G.V. Black. And here is the father of dentistry in America, not Pierre Fauchard from France, but 200 years earlier. But you're reading what the smartest dentist knew a century ago, and you're just like, wow, they had no idea. So it's going to be that way 100 years. But right now, you see, when you say perio is linked to heart disease or whatever, the research fanatics are in there saying, is correlation causal? No, yes, no. I mean, but it just makes sense that the whole body is all, working together.
Well, they've done a ton of research that's been published in dental journals, medical journals, basically linking the bacteria that is in the biofilm in the pockets to cardiac problems. They find it in hardened arteries. They find it in the pancreas. They find it elsewhere in the body. And it's those specific bacteria we only find in the mouth. And they find that those patients who don't have severe disease, oral issues don't have those severe diseases. So there is definitely, it's not a casual relationship. It's definitely been linked in the literature. But, look at it this way. 30 years ago, when you were in dental school, how much of that, what percentage of that information has changed in that time? And I'd say probably 80% of what we were taught in dental school is no longer valid today. I mean, things have changed drastically. And you say 1,000 years, I think in 20 years, things are going to change drastically, that anything we learned in dental school is no longer will be valid.
Well, you know what I find interesting reading 100-year-old dental books and 70-year-old dental books is those dentists knew they would see a sickly person and jaundice eyes. I mean, they spelled out in detail and a whole mouthful of pyorrhea, and they would pull all their teeth and they would document how the person just looked and felt much better as soon as they got all that infection out of the mouth. And I'm like, wow, now it's 100 years later and they're starting to say, yeah, those bugs in the mouth are making you sick.
Yeah. Oh, exactly. But now we have the literature and the proof to back all that stuff up. It's just not somebody's opinion. Remember toothworms. We learned about toothworms in the 1800s. They believed that's what caused tooth decay. And they found, well, that wasn't true because they didn't know anything about bacteria. Now we're understanding bacteria does a lot more damage and does more stuff than it did, years ago that we were aware of. But the key is there's a difference between planktonic bacteria and biofilms. Planktonic bacteria is just bacteria floating in your blood system or in your saliva. That's easily killed. The body can take care of that. But when you group it together in a biofilm, it's very resistant, up to 1,000 times more resistant to antibiotics. It controls the environment to protect itself. And that's what causes a lot of the issues. And we're just now starting to understand that.
So how are you managing? I mean, you lecture and write on everything. How are you managing your perio patients today differently than back in 1986? And how are you managing perio around implants?
Well, what I used to do basically is I follow what we were taught. I'd scale and root plane. I'd put them on, home care, which was basically brushing and flossing and hoping that they were brushing and flossing, and then get them back every 3 months. And I found that a lot of those patients, it wasn't getting better, or it was pretty much staying in I wouldn't say it would plateau, but still get bleeding and still have issues. Bone would still disappear, and it really depended on the patient's particular resistance. Some patients, the bone melted away no matter what they were doing, and others it didn't. So I started looking for better ways to do this, and I actually stumbled on using the Picasso diode laser when I'm doing my scaling and root planing. I run that through and kill the bacteria as much as I can, scale it, and run it through again to clean up the tissue. And then I'm putting them on what we call Perio Protect trays with a 1.7% peroxide gel. And I'm putting them on this 3 to 4 times a day for usually 4 to 6 weeks. I get them back. I check. If there's no bleeding, I start cutting that down to about twice a day, get them back on a 3-month recall. And I find that we're seeing less bleeding. We have higher patient compliance. And the patients are saying that everything feels better. I'm not seeing the tissue receding anymore. I'm not seeing bone loss. And I think it's made a big difference.
Now, these are like the Perio Tray. This is like you make like a bleaching tray, a suck-down bleaching tray?
No. You really need a custom tray, and it has to be through the Perio Protect people. What you do is you send a full charting of the pockets, and they custom design this so that there's a seal around each tooth on that model, so that it's not like a regular custom tray. We need to basically create a seal so when we force the peroxide gel down into the pockets, it stays there and creates basically a hyperbaric oxygen chamber.
What's the website of Perio of this place?
It's Perio Protect, PERIOPROTECT.com, perioprotect.com. And basically, you send them a full charting, either impressions or good study models, and they basically then customize that tray to fit that particular patient's pockets on each individual tooth. A regular bleaching tray is not going to create the seal you want. You have to be able to force that stuff down into the sulcus. The problem is our natural reaction is that we're producing fluid in the sulcus or the pocket to force bacteria out. So if we basically try to irrigate something in there or use a bleaching tray, that sulcular flow just pushes everything right back out. So we need a special tray, the Perio Protect tray, to force it in there and hold it in there for the correct contact time, which is about 10 minutes.
Now, would that tray be better even for bleaching? Because I know when Rod Kurthy started his core bleaching system, if you really looked into that, I mean, 99% of what he was talking about is the attention to detail to making the tray.
I haven't used it for that, but it probably would, because it would seal the bleaching solution onto the teeth better. But the key is we don't want to force that bleaching solution into the pockets. It may be that the bleaching solution would be forced into the pockets and cause an issue. One of the interesting side effects of using the Perio Protect and the 1.7% peroxide is we do see a little bit of whitening of the teeth. Not a lot, but a little bit. And the patients I've used this on, when they come back for recalls, they say, hey, I noticed my teeth are a little bit brighter. So that, it's a good side effect.
And who's the founder of this Perio Protect, and where are they out of?
They're based in St. Louis, and it's Dr. Keller.
St. Louis, Dr. Keller. From Keller Labs?
No, different person. He's a dentist.
Dr. Keller, Keller?
Yes.
And how long has he been doing this?
He's been doing this for, I believe it's a little over 10 years.
Well, let's get him on the show. Is he your buddy?
We can talk to him.
Yeah. Email me, howard@dentaltown.com, and CC Dr. Keller. Slow down, Spanky. What's in that tray?
It's a 1.7% hydrogen peroxide gel.
And why do you like that as opposed to chlorhexidine gluconate?
Well, the problem with chlorhexidine is that it works on young biofilms, but if you have a mature biofilm or one that is nutrient starved, it has no effect on the biofilm whatsoever. The good thing about the peroxide is it sort of like an onion peels layer by layer of the biofilm off, getting to the bacteria and then breaking those down. Also, the bacteria that's in these biofilms is anaerobic. So the peroxide basically liberates oxygen, changing the environment, making it really uninhabitable for the anaerobic bacteria. So we were able to change everything around.
Well, that is now. When you said you use a diode laser, I want you to slow down on the diode laser, because these dental students are walking out of school with $300,000, $400,000 in debt, and they see a Perio Lanap laser, but that program is 125, 135, and you're talking about using a Picasso diode laser, which is what, 2,500? How much is?
You're talking for the light. I believe it's $3,500 for the Picasso light from AMD Lasers, which works adequately for this. They do have the full Picasso laser, which has higher wattage. If you're doing surgeries and stuff, that's a little better. And that one I think is $5,500. But the $3,500 Picasso light works great, and you don't have to spend a lot of money to be able to do this stuff.
So the 35. Explain again the name of the 3,500 versus the 5,500 and what.
It's the Picasso light.
Light, LITE.
LITE.
Okay, Picasso light, and what does that not do that the $5,500 one does?
That one has the new one has 3 watts of power, where the full Picasso has 7 watts. So the only difference you're going to find is if I'm cutting very fibrous tissue, I need more wattage in those cases. But for the average dentist, what they're doing, the Picasso light works adequately well.
So then what's the value proposition of upgrading from a $5,500 7-watt Picasso to a $135,000 Lanap, which includes a training?
Well, I mean, they're basically indicating with the more expensive laser, they're indicating that they're getting bone growth and some other stuff. They patented the LNAP procedure in the name, but I'm not using that type of laser in my practice. I think I'm getting very good results. I'm seeing improvement, especially when I'm combining it with the Perio Protect trays.
And what type of laser is the diode laser versus the Lanap?
One's an ER-YAG and the other is a diode. So the AMD lasers are diode lasers, and the Millennium laser, which is what they're using for the LNAP, is a ER-YAG laser. And
then the Perio Tray gel is a 1.7% hydrogen peroxide H2O2?
Yes.
And you're doing this if they have periodontal disease around natural teeth or periimplantitis around implants?
Yes. See, the problem is biofilm sticks to everything, and what happens is your body sees this insult in there. It sends white blood cells, and the biofilm is able to actually deactivate those white blood cells. So after about 3 days, the cells lyse themselves, killing themselves, releasing all the enzymes that they intended to kill bacteria with, and that's what leads to inflammation and bone loss. So if we can get rid of the biofilm, we don't have to worry about it destroying the white blood cells and them causing the damage in the bone and soft tissue.
I've had a breakthrough this last month with a patient where I'm sympathetic to gaggers because I got 5 sisters and a brother, and me and my sister Kayleen are the 2 gaggers. The biggest problem we have when we're brushing, it's just our gag reflex. And I can't even, I've never been able to brush for 2 minutes. I brush for like a minute at the beginning of the shower and a minute at the end. But anyway, I told her to get an electric toothbrush and just dry brush because Trish O'Hare was the hygienist who been saying forever that it's not the toothpaste, it's the brushing. And she always promoted dry brushing. And this lady came in and she just massively, finally after, I think she's been a patient for 18 years, and it massively went down. She got an electric toothbrush, put it by her nightstand, and when an alarm goes off, she just sits there in her bed, dry brushing with an electric toothbrush, and she does it before she goes to bed. And now she's doing that every morning, every night with electric in her bed without any toothpaste. She can brush for a long time without gagging, and it made a huge difference. And I'm really excited about that. Have you heard of the dry brushing techniques?
Oh, yes. But you also have to realize that people are lazy. They're not going to brush for long periods of time. Studies have shown you really got to brush 3 or 4 minutes. Nobody does. Everybody brushes for a minute or less. If you use an electric toothbrush, it's more effective than hand brushing, whether it's wet or dry. And so you say, all right, I can't increase how much time you're going to brush, but if I increase the efficiency in that period of time, we're going to get a better result. But I think, home care is great. It really helps with a lot of the stuff. The only problem is those toothbrush bristles can't get more than 3 millimeters down in a pocket. So if you have a pocket that's 4, 5, 6, 7 millimeters or deeper, we can't get down there to clean it with any floss, toothbrushes, or anything else. And if you give a patient an irrigator and say, here, I want you to use this, they don't use it. You're going to spend 20 minutes irrigating around every tooth. Nobody does that. So we really need something that increases compliance for the patient, make it as easy as possible. And I have a perfect example. I have a patient in my practice who's in a group, networking group I'm in, and he comes in and he says, I know I got a perio problem. I just don't like brushing. I don't like doing this. I don't like doing that. He's got pocketing. He's got bleeding. I said, let's put you in the Perio Protect trays. And I got everything cleaned up. I used the laser, got him recall. And I say, well, you're using it twice a day now. How is he? Goes, it's not that bad. I put it in. I drive to work. I take it out when I get to work. I do the same thing on the way home. I got my 2 times a day. I said, all right, we can cut down to once a day. He goes, it's not that bad. It's such a habit now. It's so easy to do. Why don't I just keep doing it twice a day? I said, that's great. The more you do it, the better. So, the compliance I find is very easy with these, but it all adds in. You still got to use a toothbrush and floss.
So you're using the Picasso Light 3-watt for disinfecting solvents, but the 7-watt you would be doing pocket elimination.
No, you can use the 3-watt for pocket elimination too. Where the 7-watt comes in, if I'm uncovering an implant and I have very fibrous tissue, I can't get enough wattage sometimes out of that 3-watt laser to cut through very fibrous tissue. So I find that the 7-watt works better in those cases. If I'm doing a peri-implantitis treatment where I have to disinfect the implant surface, I want to use the higher wattage laser. But the 3-watt laser works great for bacterial reduction in the pockets, debridement of the pockets after scaling. Pretty much 90% of what the average general dentist is going to use, a 3-watt laser works perfect.
Okay, and just not to beat a dead horse, but let's beat a dead horse. This is Dentistry Uncensored. You know that for every person using a diode laser, 3 are using an Electro Surge for the same thing. What are your thoughts?
I'm really glad you brought that up.
Really?
I'll give you my how I started in practice. 12 years I used a Monopole Electrosurgery unit. And I found out I had a lot of inflammation, a lot of tissue shrinkage. The patients had discomfort for a week, 2 weeks afterwards, no matter what wattage I set it at. I moved into bipolar electrosurgery, which is now off the market. I used that for about 12 years. And then I started moving into diode lasers. And I find that with the diodes, I can use that around metal fillings, amalgams, crowns. I can use it around implants with no negative effect at all. The problem with a monopolar is it's a circuit. If I get anywhere near an implant, it's going to pick the path of least resistance, which is through the implant, then through the body. And I could see deintegration. It's been reported. I've never seen it myself because I don't use them around implants. We can deintegrate those implants. So they're really not, in monopole electrosurgery, no matter what anybody says, the literature shows, and Wallace's article was key in this, we cannot use those around implants. And metallic fillings are the same way. We're going to ground right through that metal filling or crown.
But just between me and you, what percent of the American dentists are still using Electro Surge anyway?
I don't see as many advertisements for Electro Surge anymore. I think the big company is still Elman. I think some of the other smaller companies have really phased them down. They're not selling much. Seems like there are a lot of companies selling some form of laser. And as the prices come down, you're talking price-wise, if I'm going to go out and buy something, what it's going to cost me to buy, let's say, a Picasso Light is almost what it's going to cost me to buy a Electro Surge unit. So why not use something that's safer and gives me a better result? I get no tissue shrinkage with the laser. The patient, in a lot of cases, I can probably use it without any anesthetic or maybe just some topical. I can't do that with monopole electrosurgery. If I'm basically going around something and I want to remove some tissue and take a crown and bridge impression, with monopolar, I had to wait 2 weeks because I'm going to get some tissue shrinkage. I don't get that with a laser. I could take the impression immediately.
Let's go back in the day, scaling and root planing around teeth. And I still get questions all the time. Do you scale and root plane the titanium implant with periimplantitis? Do you use any metal instruments when you're cleaning around periimplantitis, or?
I prefer to use a plastic instrument. They do have plastic tips that fit onto ultrasonic and piezo surgical, tips. The key is if you put metal to metal, whether it's a titanium tip on a Cavitron or a stainless steel one, it's still going to gouge the metal. And if you have a rough surface due to gouges, you're going to have more plaque trapped there. So you really basically have to be really careful on these.
What about all the other things that people are using for perio? They put perio chips, Atrodox, some just use systemic antibiotics. Are you doing any of that?
I've moved away from that. The problem with the perio chip that I didn't like was it was like putting a wet noodle into a pocket. It was hard to get in. If you refrigerated it, it was easier. But we find, and as I mentioned, chlorhexidine doesn't really do much to biofilms. Antibiotics, remember what was the string one? It was like a rubber band you had to put in there. Those things were impossible to get in there. They wound up popping out after a day or two. Acticite and some of these others that you inject in, they tend to get a little on the expensive side because they're really designed for specific sites, not the whole mouth. And most patients coming in have like multiple sites, so it's a fortune for these patients to pay for this stuff. And as we said, biofilms could be up to 1,000 times more resistant to antibiotics. So if I put an antibiotic in there, it's not really doing anything.
And I see them talking about they've discovered this year, Relic Christian was telling me that they discovered that now fungi, candidiasis is in that plaque matrix, making it even more impenetrable to the. So it's kind of like Streptococcus mutans taking advantage of a fungus, making it more impenetrable. So go ahead.
They found in the literature actually a lot of sinus infections were actually fungi related. So we were treating sinus infections with antibiotics, and it turns out a lot of these are yeast and other fungi that are in the sinus. So that's something we've tended to like push aside and ignore because we focused on bacteria. But as you said, they do have an influence also. In a compromised site, everything sets in.
We're doing a podcast coming out with a local rhinologist, a local ENT, and basically the story is, and I've heard it several places, that now that endodontists are getting CBCTs and dentists are getting CBCTs, that a lot of people who think they've had sinus allergies for the last 10, 20 years have a failing root canal into the sinus, and these rhinologists get in the sinus, exactly what you said, candidiasis, plaque, just long-term chronic infections. A lot of these, they're surprised. Oh, you got a cat too?
I've got 4 of them.
You got 4 cats? Oh my God. I'm so jealous. I'm only half the man you are. I only have 2. What's your cat's name?
This is Zippy. So we have April and we have Bailey and Bear.
It's so funny. My Mimi only wants attention when I'm staring at someone else on the computer. And then if I wasn't talking to you, she wouldn't talk to me. But since I'm talking to you, she has to get in my face. But these rhinologists are saying that CBCTs have been a game changer in sinusitis because they just had no idea how many of these were odontogenic origin. And a lot of these dentists listen to this need to start. I think if we've reached the point where we gotta start asking, do you have sinus problems? Because a person will just say it's something in the air, it's something blooming, it's something whatever. I'm allergic to this or that. But you're a dentist, and you got to rule out odontogenic origin. Are you hearing this too?
Yeah, I do hear that also, and it's interesting because being in the DC area, we're in allergy central because everything grows here. So everybody here has allergy issues. That's not a problem. It's funny. I had a patient came in some years ago, and he had tooth number 2 treated, endo retreated, and it still wasn't right. And he was missing 3, 4, and 5 and wanted implants there. And he brought a cone beam in with him, and I'm looking at the cone beam, and I said, "Here's why it's bad. You have a lesion that you can't see in a regular X-ray that we could see in the cone beam. That it basically is up in the sinus." So his answer was, "I've had it treated, I had it retreated. Let's just get rid of it and put an implant in there also." So we are seeing a lot more with the cone beams, especially with sinuses and other things that we really weren't aware of before.
So what else did you want to talk about? You want to talk about perio? Did you want to switch subjects?
Well, we could stick with perio for a little bit.
Okay. What else do you want to educate us on perio?
I think that the things have changed a lot. We have to realize that there is a connection, especially in our older individuals. They're really prone to aspirating plaque and biofilm into the lungs, and that's why a lot of them have respiratory problems. So maybe those senior citizens, we should put them on like Perio Protect trays to prevent this and improve their overall health. Diabetic patients, same thing. It's like, we know there's a big link between perio and diabetes, and if we basically control the perio, the diabetes gets better. And we're not going to eliminate the diabetes, but we can make it better. Prostate cancer, we're seeing a big interconnection with biofilm. Colon cancer, preterm birth weights, early pregnancy issues. There's a lot of things that are interconnected with the perio in the mouth. So I think that, we really need to start focusing more on stop being those tooth mechanics and really be healthcare providers.
And the hygiene department really is the lifeblood of the dental business. I mean, having these patients come in regularly is the lifeblood. I mean, it seems like anytime you see a dentist, if they got 2 full-time hygienists and then the dentist has 2 chairs, 80% of what they're doing comes out of just a routine seeing these hygienists every checking 2 hygiene hour and 20% emergencies and new patients and whatever. And it just seems like that's the foundation of the biggest, most successful dental family practice I see, not whether or not they become, an implantologist or start doing ortho or become a cosmetic dentist or a sleep doctor, all these other things, which are all cool. But it just seems like 80% of all the very successful family practices, it's just 4 chairs, 2 hygienists, the dentist works 2, and then an overflow emergency 5th room operatory. So, just focusing on 2,000 people and really taking care of them is the basis of a really successful dental office.
Oh, absolutely. Absolutely. And just before we move on to another topic, next month in your magazine, I do have an article coming out on oral biofilm and how to treat it in the Dental Town magazine. So I wanted to mention that.
And thank you so much for writing that. And any listeners that want to write an article, a lot of people are confused. They think that I have something to do with it. I don't. I have Tom Giacobbe. He's been the editor. I mean, he's worked for me since 2000. I think he's amazing. You can email him, is it Tom at dentaltown.com or Tom at Fran Media? Do both of those work for Tom? Yeah, Tom at dentaltown.com or Tom at FranMedia.com. But Tom Giacobbe, I was CC'd on some of those emails. That was an amazing article. So thank you for doing that.
Oh, my pleasure.
Will I be article 451?
Well, actually, I'm almost at 500, so we're pushing it.
You're pushing it.
Yeah.
So what else is hot and what's not?
We could talk about lasers a bit. I think that lasers are really changing the way we're practicing. I think the diode laser has come down a lot in price. It really is affordable for all practices. And how many times do you have root caries and you can't get that tissue out of the way or it's inflamed? Diode laser, it's easy to trim the tissue. You don't get any bleeding or very minimal bleeding, and you're able to treat the caries right there. So I think that makes a big difference in how we practice. I haven't used cord in years because I just hate it for crown and bridge impressions. I run the diode around that, and I get a nice open sulcus. I don't have to worry about the tissue shrinking. It just makes crown and bridge impressions much easier.
And are you using 3-watt light or the 7-watt?
I have both of those in the practice, so it just depends on what room I'm in.
So it doesn't matter which one?
No, well, if I have like a lot of fibrous tissue, I'm using the 7, but most of the time I'm using the light, or I'm using the 7 set at a lower wattage.
You just opened up a can of worms because you said root caries, so I'm going to hold your feet to the fire on that. I always felt that's the 4,000-pound elephant in the room that no one talks about, is that we take care of these people for a lifetime. The men are lucky; they just they just walk away and drop dead. But the women just keep living and living. They live 5 years longer than the men. And the nursing homes are pretty much all women, and they're getting a root surface cavity, a new one, every single month they're in a nursing home. So after grandma's been in there a year, she's got 12 root surface caries. And I'm telling you, I'm in Phoenix, which is a big retirement area. And dude, those are hard to manage. It seems like they're like brush fire. How do you, what do you do when you get 82-year-old grandma and she comes in, you saw her 6 months ago, she's fine, and now she has 5 root surface caries?
Well, part of that is dry mouth issues. They're not able to keep clean, but putting those patients on a neutral brush on sodium fluoride or something in trays is going to help limit that. And you said an 82-year-old patient. Well, last week I had a 100-year-old patient came in on a lower premolar with root caries that turned into a root canal. And she's missing, I think, 3 teeth in her entire mouth. But she's in pretty good health for 100 years old. So I said, she goes, isn't there another alternative? I said, I could take the tooth out. Well, I don't want to do that. So we did a root canal on it. But the root caries, which wasn't there 3 months ago, now was right into the pulp. So we do see those problems. And as you say, we're seeing it more in females because they tend to live longer. I'm not sure if women have more dry mouth issues than men do, but they tend to be on a lot of medications, older populations, and that contributes to dry mouth. But, we're basically seeing a lot more of that stuff as people are living longer and longer. And just like you said, it's like they come in, you come back 6 months later, and they got a whole mouthful of them where they didn't have it at the prior visit.
And back to when we started this conversation talking about mechanics versus biologists. I mean, I still see most root surface caries being treated with just an inert plastic composite straight out of Ivoclar or 3M, but you're seeing other composites like pulp dent. You're seeing GC, where they're trying to make a filling material that tries to become more bacterial static or have some mechanism to fight these bugs. Do you believe those mechanisms are more successful than just a straight resin inert composite?
Well, I don't know if you know Gene McCoy, who's the big abfraction guy. He's in San Francisco. Gene has been studying abfractions for like 30 years. And I think that I sort of learned a little bit from him that a lot of this stuff, the tooth flexes. And I found that when I was putting hybrid or nano composites basically on the root surface, they tended to pop out or they re-abfracted or we got decay at the gingival margin. So I really moved away from that and went into flowable composites, which had a little bit more flexure. I've used glass ionomers. And the thing I like about the glass ionomers, and you mentioned GC, they have a new product called Equa Forte, which is a stronger, you could actually use it for class 1s and 2s, but it's got fluoride release. So we're going to decrease the chances of getting more decay around those margins. Plus, it stays in better. The problem is a lot of people advocate, oh, you just don't have to prep these things very much. You just clean up the decay, and we're going to bond it in there. And I find that I'd rather put some mechanical retention too, because it's belts and suspenders. I want to make sure that it doesn't pop out. And I find that I'm having fewer problems when I'm putting a little bit of mechanical retention in, as well as trying to rely on some bonding.
But do you think these filling materials like glass ionomers and stuff out of GC and pulp dent, do you think these things have a statistically measurable effect of having less recurrent decay or slower to get recurrent decay than something inert?
I believe so, because they're releasing fluoride. So I think, and the fluoride recharges itself. So if we have fluoride there, we're less likely. You have to realize decay results from calcium ions being pulled out of this tooth structure. Well, fluoride ions can take up the same kind of biomolecular spot. It takes more acid to pull the fluoride molecule back out than it did calcium. So if we have fluoride in the area, really are fluoridating that dentin surface, we're more likely to see longer progression or less problems down the road due to future decay. But a lot of this also is like dry mouth issues. You get rid of the dry mouth or manage that, they have much fewer root carie issues.
And I know you've lectured in too many countries to count. You've lectured all over the world. Seems like every time I see you on Facebook, you're from another country. Why do you think glass ionomer is more popular in Australia and New Zealand and Japan than the U.S. and Canada?
Well, I think Japan, because a lot of these products are developed in Japan. So they're pushing that there. I think that we see a lot of materials used in other countries, not in the U.S., that are easier to place. Glass ionomers are easier to place because we don't have to bond them in. They're self-bonding. So I think from that standpoint, they really grasp those things. Here we have a tendency, we don't want to look at any research outside the United States. It's not valid unless it happened here. And we have a tendency to move in one direction. I think we're opening our minds and looking at more stuff these days. And I think the glass ionomers are good materials. They've gotten better over time. The initial glass ionomers were very weak materials. They were good for a liner, but they really weren't good for anything else. Now they have stuff that is really abrasion resistant that really holds up long term fairly well.
I think the internet is a massive game changer because I know when I started Dental Town magazine in 1994, every single dentist only read a magazine from their country. And then when the internet came out, it was really not even to maybe Facebook started in 2004, and it's probably about 2009 before you really start to spend the first time in their life. It didn't matter if they're in Romania, Poland, or the U.S. saying, "Hey, did you hear about this? What this guy said in Argentina?" And I knew that was going to be just a massive game changer because we're going from our own tribe to a global tribe.
Absolutely.
Yeah, and I really think it's just a huge game changer, right? And I still think it's silly that some of these companies, like GC's one, where they sell the exact same product under several different names in several different countries, and I think that's got to stop.
Well, part of the reason for that is what they call gray market materials. What you'll do is you'll buy a product in, let's say, Romania for $25, where that product sells here for $100. So what they do is they import it into the United States, some small distributor, and sells it over here. So they basically have no control over that stuff. So what they do is they name it different things in other countries. So you know if it's the ABC material you're using here, and they're trying to sell you the BCD material, even though it's the same company, you know it's not the same product. It didn't come here, and the standards for manufacturing may be different in other countries. So that's why they basically rename things in other countries.
Oh my God, I can't believe I didn't figure that out until you explained it to me. I mean, when I can't figure something out, I usually go with, well, money's the answer. What's the question? And it was money. So it was geographic price discrimination, where they sell things for a lower price in poor countries and a higher price in richer countries. That's why they do that.
You've been to India, haven't you?
Yeah.
I mean, look at what you pay for a dental product here. You think they could afford to pay for that same product, that same price in India? They can't.
I know Indian dentists in the United States that go home and visit family and take a big empty suitcase and buy, $1,000 worth of stuff in India, and then they bring it back, and it would be $10,000 in the United States.
Oh, absolutely. Yeah. So next time you're going overseas, let me know so I can give you a suitcase to bring back stuff.
Yeah, and American pharmaceutical companies are the worst. These pills, $10 a pill here, they sell for 50 cents in Shenzhen.
Well, it's funny because I had a friend who was doing a lot of Botox and used to be able to get it from Canada for like a third the price that the material cost here. And now FDA has basically said you can't ship the stuff into the U.S. And it's the same exact product from the same exact company. It's just that they sell it a lot cheaper outside the U.S. because they're greedier here, the pharmaceutical companies.
Well, we'll talk about that. There's some big threads. There's a big thread right now going on Dental Town about gray market, black market. I think the name of the thread is gray market, black market, yellow market. What's it all mean? Did you want to weigh in on that? What does it all mean?
Well, I mean, there's a difference between gray market and black market. Gray market means it's the same. The ABC company has made a product. They're selling it in another country. Somebody buys it and brings it in here and sells it, marks it up. They're making a bigger profit. Black market means that they're basically taking that product and they're making something similar to it. It's not the exact product, and they bring it over here and they try to sell it as that product. So with black market products, you have no idea what it is. It might say it's whatever the product is, but it's not exactly that product. Where gray market, you usually assured it's about the same product. But it is because the companies are, over the last 10 years in working with the companies, their big problem is the gray market and black market products. And I can understand from a profit standpoint, they're having issues. They're more concerned with the black market products because if you're used to using the ABC product, and you get a box and you think it's the ABC product, it's a black market, and it's not the exact same product, you go, God, this was horrible. I had horrible results. I'm not using this product anymore. So what happens is they lose your business. So they're more concerned with the black market stuff than the gray market stuff.
Interesting. And it's not just a rich country problem that we're paying more for something sold identical in Brazil or India or China. When I go to very, very poor countries, one of the problems they have is one guy bought the country's distribution rights to a product, and then he just marks it up 100%. And then they're like, I have to go get in my, so they go to these international dental conventions to buy the stuff half off and then sneak it back into their country just because the distributor's marking up 100%.
Well, it's interesting you mentioned Romania. I was in Romania lecturing a few years ago, and a friend of mine who's a dentist there who does a lot of implants. We're talking, and he says, what would it cost to have an implant placed and restored in your country? I said, probably about $4,000. He says, you know what it is here? I go, I don't know. He goes, $800 total. I go, really? He says, we can't afford to buy an implant that's a name brand like Nobel or one of those that costs us $300 and then have to pay for the abutment head and the crown on top of that. There's no profit margin. We can't make anything. So we have to buy something that's $150 that has the abutment head included, so we can basically then get a crown made for another $50 or $75 and still be able to make some money on it. And they couldn't, some of the big companies couldn't understand why they can't break into these smaller countries or these poorer countries, because the economics, so they say, well, we can't sell an implant there for $300. They don't understand that. The economics just doesn't work in those countries. So that's why, some of the big implant companies are not selling in a lot of these smaller, poorer countries because they can't mark the thing down to it.
And Danaher's really playing the GM route, where GM's got, a Cadillac, and then they got, a Buick, an Olds, a Chevy, and, Danaher owns the high-end Noble Biocare and the low-cost Implants Direct, so they're serving two markets under one company.
Well, one of the companies now, a very large company, I won't mention their name.
It's Dentistry Uncensored. Mention their name.
Dentsply. And it's interesting. They this is before, or as they were getting ready to buy Astra, a Korean company called DIO. And I said to them, you combining everything into one? He goes, no. I go, why? He goes, and it made perfect sense. We're keeping DIO separately so we can sell that implant. It's a lower cost implant in other countries that we can't sell our other implants into because they're too expensive. So what happens is if we combine it into one, somebody's going to say, why do I want to buy the Astra implant or the Zyve implant? I'll get a DIO implant, the same implant for less money. So they basically were smart in how they compartmentalized that. I think Danaher has done the same thing. They'll never combine Nobel and Implant Direct because they're going to two different markets. And if you have them under the same roof, what happens is people say, why should I buy the Nobel implant? I'll just buy the Implant Direct. You're selling the same thing. They got to be similar quality.
So who started Astra? Was that Niznik? Jerry Niznik?
No. Niznik basically became Implant Direct.
But what was Niznik's first implant company? Was it Corvent?
It was Corvent, and then Dentsply. Jerry was kind of interesting. He had Corvent was two companies, manufacturing and distribution. Dentsply bought distribution. 5 years later, they made him buy it back at really at a discount because the price of the distribution had come down a lot. So then he couldn't use the Corvent name anymore, so he formed Paragon. So he had Paragon Implants, and then Zimmer bought that. And then what happens is he had to stay out of the business for, I think it was 5 years. So he stayed out of the business, and then he came back in and formed Implant Direct, and eventually Danaher purchased that.
And that 5 years is about up, and rumor has it he's going to be back.
That 5 years was 10 years ago. So he was back in, and then basically Danaher had an agreement with him that after 5 years, he basically was out of the business again. So he basically, my understanding on the agreement, I could be wrong, is that he cannot come back into the business or his family for a long period of time because they basically didn't want to have to deal with any issues.
But I think that long time is over now.
No, not this one.
I hear he's back. Back.
There's some suits and countersuits going on, but we'll see what happens.
Well, I emailed him the other day, and he says, just give me a little more time. He says, I'll come back and do a podcast and tell you what's next. I don't know what it is. Maybe it has nothing to do with implants.
I haven't spoken to Jerry in a while, so you may have more information than I do at this point.
An amazing man. So what next? What else you want to talk about?
Whatever you want.
Well, I really want you to go back and talk about that Dental Town Continuing Education course you put up because, and by the way, that was in 2010, dude. It's 2016. Are we going to have the honor of getting another course from you? And
I'm sure we can do
you
something.
know why our courses are exploding now is because now you can take an online CE course on the Samsung and app. As far as the iPhone, Apple told us they kept making a few changes, but the iPhone should be online CE should be released. And now that these dentists, there's 210,000 members on Dental Town, but 40,000 of them download the app on their phone. And once they start taking online CE on their Samsung, it exploded. So the iPhone is right around the corner. And when people log on to Dental Town from their app, it's about 80% iPhone. So I'd love to get another course from you, but I want you to go back and talk about your 2010 course, Core Billows, Post and Core, and Understanding Ferrule, because I think a lot of dentists believe that you'll even hear them. They'll just say, well, if I don't have any retention, I'll just put it on with Panavia because I know that won't come off. So when some dentist doesn't have any retention, he says, well, I'll just use Panavia. I don't think they understand the ferrule. I really don't. And I also don't think they know when to post and not to post. Can you address those two deals? What is the ferrule?
Sure.
Is this crown going to stay on from? And then I also want you to address Carl Mish was on here for a nice podcast saying that that he doesn't like these resin cements. He says they don't show up on X-ray, and and bacteria and biofilm watch them, and he wants people to go back and use the zinc phosphate cement that shows up on X-ray and kills bugs. So answer those 49 questions.
Okay. Question number one. Basically, a ferrule is a vertical band of tooth structure that the crown wraps around, and it comes from the barrel making industry, and that was the circumferential band that held the slats for the barrel together. So if we look at it from that standpoint, the studies have shown that we need at least a 2 millimeter high ferrule around the entire tooth in order to prevent lateral tipping and force that crown off the tooth.
You're saying that was a ferrule was the name of the metal wrap around the barrel?
Yes, that's where it comes from. Yeah, it just basically it's ferruling the barrel all together. So basically what we have to do is we have to have this ferrule there. And the problem was that when we went to dental school, we weren't using adhesive cements, everything else. Well, as adhesion dentistry came along, people started developing this attitude, I can glue everything together. I can use Panavia or whatever, and I'll glue everything. I don't have to worry. I could have two flat surfaces, and it's going to stay on forever, and it doesn't. The problem is that we're moving away from engineering, and we're using materials that are not designed to be used the way they are. Panavia is a great cement. It's a phenomenal cement, but it's not going to hold a flat surface to a flat surface long term. And this is more critical in the upper anterior because of the tipping forces or the direction when you lower teeth meet the upper teeth. It's not in a long axis. So what we have to do is we have to have a ferrule around the tooth. We also want to maintain as much tooth structure as possible. And if you look at when rotary endo first came out, they were using very wide files that are 08s, 10s, 12s in diameter in order to basically blow out as much cervical tooth structure. They weakened the tooth, and that's basically why it broke. We've moved in the direction where we're using 04 and 06 tapered files. We're maintaining as much cervical tooth structure as possible to maintain as strong a tooth or a base as we can. The question is, when do we use posts? When do we not use posts? I still use posts. I use fiber posts. I don't use them all the time. If I have let's say a tooth that has just a filling, an occlusal filling in it, both marginal ridges are intact, I will just fill it up with composite when I'm done with it, and that's it. I'm done with the restoration. If I'm missing one or more marginal ridges, I'm putting a crown on that. I'm not a big believer. Inlays, I think, act like a wedge in a piece of wood. Onlays you can do, but the cost of an onlay lab-wise versus a crown is about identical. So I'd rather put an all-ceramic crown on the thing and really hold it together. When do we use posts? If I'm missing enough tooth structure that I really need to retain that core better, we have to realize the post only holds the core in. It really, I don't think, strengthens the tooth very much. So if we put a post in there, a fiber post, we're able to bond to it. And what I believe, even though those posts are silinated when we get them from the manufacturer, you really need to re-silinate them to get a better adhesion to it. Because what happens is your resin cement is only going to stick to the resin part of the post, not the glass fibers. So what we do is I silinate it, I put an adhesive on it, I light cure that, now I have a better bondable surface. I like to use a self-etch resin cement like Panavia is a good example. I place that into the post-prep. I make sure my post-prep is no bigger than the final endo file I used, so I'm not blowing out more tooth structure to get a post in. On multi-canal teeth, I'm putting one post in each canal to really pin that core in, and I'm basically then bonding everything in using adhesive dentistry, then putting a crown on top of that. Now, if we get to what Carl said about cements, I have to agree with him.
I'm sorry, you didn't name what type of resin post. You mentioned the cement was Panavia, but what brand of
there's a lot of good posts on the market. Most of the companies, tapered fiber posts or tapered fiber posts. I don't think there's a lot of difference between company to company. GC makes good posts. There's a lot of different companies that make good fiber posts. There's not a lot of difference. I haven't used a metal post in years. And the reason for that is when you overload a tooth with a metal post, the stress concentrates at the tip of the post. That's when you fracture the root. When you have a fiber post and you overstress it, they tend to break coronally up above the cervical. So we can restore that tooth by putting a bigger post in if we need to. But I've seen a lot of failures with metal posts.
And just one question: if that root canal failed and you sent it to the endodontist, what's he think about the metal post versus the fiber post on a retreat? Does that factor into?
Well, usually if the metal there's a metal post in the tooth and it fails, usually you extract the tooth because it's fractured the root. Where I haven't really seen any fiber posted teeth fracture roots.
But I'm sorry. I meant can the endodontist get that fiber post out? Or
yeah, the restorative dentist can. All you do is you take a pointed diamond and you go down the center of the post a little bit, and then you start working hand files down. Because you got to realize a fiber post is parallel fibers of glass. So all you're doing is working down through that between those fibers till you get past the post, and you laterally widen that to remove the post. So it's not that hard to get a fiber post out.
Okay. And then you were going on next?
Well, what Carl was saying about cements and everything, I have to agree. The key is, when I first started implant dentistry, everything was screw retained. And then basically everything moved into cement retained because they didn't have a lot of techs that were really good at doing screw retained. And general dentists wanted something that was easy, that was similar to crown and bridge on natural teeth. So that's the direction it moved in. Then when we started doing a lot of immediate loading, we moved back towards screw retained stuff. So I'd say probably 90 to 95% of my implant restorations are screw retained. And part of the problem with that is I don't want cement down in the sulcus, which I can't see. Using cements like Duralon, zinc phosphates and stuff like that work very well. We can see those in the x-ray. We need retention with an implant crown. We don't need as much retention as with a natural tooth because usually the walls are a lot more parallel, so we get better retention. So we really don't need to use really strong resin cements. And God forbid I got to take that crown or that bridge off. If I use a resin cement, I'm not getting it off. I have to cut it off. If I use Duralon or another cement like that, they're not as retentive. I can tap that thing off and do whatever I have to. Maybe tighten the screw in the abutment head or whatever. Because even with torque wrenches, screws get loose.
How big a problem is screws getting loose? You got a patient on your schedule.
I think we still see it occasionally, and I think that a lot of this probably is occlusion related, because you tighten it down with a torque wrench. You say, "Oh, I know that's tight," and then the patient comes back a couple months later and says something feels loose. And I have an screw retained implant crown in my mouth on number 31, and every couple of months it gets a little bit loose. And my friend tightens it down with a torque wrench, and everything's fine. But I guarantee, I chew ice, I do other things, I'm hitting it at really weird angles, and it eventually gets it loose. So even if you check the occlusion, it's still going to it may get loose over a period of time. And the one thing that we really ignore with implant dentistry is we check the occlusion when they come in and we put their prosthetics in, and then we never check the occlusion again. And we really should be every recall checking the occlusion because things change, things shift, patients start biting a little differently. So we want to basically keep maintaining the occlusion pattern that is ideal for that situation. And we need to check that periodically.
So, Greg, why do you think my mom says I have a screw loose when I don't even have an implant?
Well, I've known you for years, and I'd have to agree with that.
I don't have a cemented or a screwed retained implant. I have neither. Hey, you just opened up another can of worms. You said the word occlusion. And I swear to God, when you're on Dental Town, the occlusion debates go around the clock since 1998. The big occlusion deal now is neuromuscular or classic Pankey-Dawson occlusion. Do you have any thoughts on that?
I'm not I'm more of a Panky follower than I am a LVI follower. Um, I think that,
Well, that just gives away your age. All that means is I agree. That just means that we're in our 50s or 60s.
yeah, I guess so. I think that I think that patients have occlusal patterns that, some of them are not pathologic. And I had a patient came into me some years ago, and she was an upper and lower partial, and she said it was the most uncomfortable thing she had ever worn. They had just made it for her. And they basically, using neuromuscular, got her into a bite pattern that she said didn't feel comfortable. And it's like, she basically was very eccentric in how she bit. So I made her new partials, and I made her in the bite that she was comfortable with. And she said this was perfect. It felt comfortable. It felt natural. So we have to look at those things. And I think that the neuromuscular people put too much emphasis on that stuff, that, it works in some situations. I don't think it works. Nothing works in all situations. So we have to have lots of different tools in our toolbox. But, that I don't think that controversy is ever going to go away. You're going to get two schools of thought. They're never going to agree on what the one principle is.
You open up another can of worms. You said partials, and I drove 3 hours south of Phoenix to Nogales, Mexico, which has the largest partial cast frame deal. A lot of labs, a lot of times you think you send this partial up the street and this man's making your lab, but a lot of these end up in Nogales, Mexico, where they do 1,000 per day. And you go in there, and to these lab guys who have worked there as long as I've been in dentistry, 30 years, and when 1,000 partial impressions come in, 9 out of 10 don't have one rust seat, cut, nothing. It just says partial. What are your thoughts on that? 9 out of 10. And I've seen this with my own eyes. What would you say to that?
Well, I think it really comes to how you were taught in dental school. I was taught that we were prepared. We had to actually wax and cast our own partial frames, so that was part of it. We were taught to do our rest seats and everything else, and to specifically state on the lap slip, this is where I want to let rest, this is where I want to clasp. I find that a lot of dentists just take an impression and just send it to the lab and say, make me a partial, and no regard to exactly how the design is. So now you have people that are maybe, don't have a lot, they're waxing and casting stuff, but they're not really well-trained dental technicians that are basically going to just, I'll design it the way I think it should be, and they really don't have that training. I think that we have to take a more proactive stance in how we're designing these things.
I'm on the lookout. I want to find someone that will build me a course on just partials, because the lab techs at the other end, they throw up their hands like, well, what do they even want me to do? How come, no rest seat? I mean, couldn't they just taken a football and made a rest seat? If I put a rest seat here, it's going to occlude the other tooth. I think it's a real issue.
Where I find it's funny when lab techs tell me that ones that are based in the U.S., that a doctor sends them something and says, make me a partial, put the rest seats where they you think they should be, and I'll modify it in the mouth on those teeth to fit it. So now what you're going to do is you're going to try to get rest seats to be the same shape in the mouth when you go to deliver it. It's kind of backwards, and it's really a lazy approach. Better to construct those beforehand, take the impression. Now you get something that intimately and perfectly fits that arch. It's a challenge with partials.
It's fun being out 30 years later and looking at all the prediction went wrong, because they literally told us in '87 that partials and dentures were just going to go extinct. And when you look at the number of units of partials and dentures, it's actually increased significantly in the last 30 years, and that they said it was going to go to zero. And another thing they predicted in '87, I walked out and bought my first CERAC 1, that the labs are going to go extinct and it all be CAD CAM, and the labs did go from 15,000 to 7,500, but it seems to me, well, what's your status on CAD CAM? Do you think in 30 more years labs will be gone? I mean, if we've gone from 15,000 to 7,500, do you think that's linearly, or do you think it's a pendulum and it'll swing back? What is your view on, Greg? What is Greg's view on a CAD CAM versus an impression and send it to a lab?
Well, first of all, you said how things, we're seeing more partials and full dentures. And I think that the direction before the economy tanked in 2005 was we were seeing fewer because people have more and more money and they were willing to go for implants and stuff like that. Then the economy tanked and people started saying, well, I can't afford $40,000 for implant restoration. So I have to go with something less expensive. And they started moving back into full dentures and partials. And, the economy is still kind of teetering, up and down a little bit. So people are not spending what they thought they were going to spend. As far as labs go and CAD-CAM, I find that most of the labs these days are using CAD-CAM in the lab versus nobody's waxing and casting anything anymore. Of course, a lot of restorations have moved to monolithic zirconia, so they're basically using that for that. And if you look at a lab, the biggest expense they have is labor. If they can decrease their labor, they could make more money and actually charge a little bit less and do more restorations to draw more customers in. So what happens is we can train somebody who is, just graduate high school or college who likes to play video games and train them how to design these things virtually on the computer and then mill them, and we're paying them less than we have to pay a trained technician who's going to wax and cast something. So I think the direction has moved in that direction. As far as in office, I don't have in-office CAD-CAM.
You don't have a CEREC?
No, it's, I don't have one in my office. But, I want to basically I want to look at something and say, this is the best material, I think, for this particular tooth. And I find that a lot of people who have CEREC, everything, to make that lease payment, everything has to be a CEREC restoration. And I don't want to basically do that. But, I think the prices come down considerably, and I think that it's moving the direction. I don't think it's ever going to replace, like they talk about intraoral impressions. That'll never replace in our lifetime regular impressions, because you're going to get maybe the upper 50% of dentists are going to say, yes, I'm going to go for this. The bottom 50 are going to say, I can't afford this because I can't charge enough to make the payments on this. So I think we'll still see impression materials. I still think we'll still see stuff going to the lab and having them do stuff. I think that we're going to see the labs move more and more in the direction of CAD-CAM because it's just easier for them. They get more consistent results this way. They're able to turn things around faster. So I think that's the direction things will keep going.
I'm sorry, we're out of time. We already went a minute. Can I go overtime with you on something?
Go on as long as you want.
We said that when you go to a lab that does 1,000 partials a day, 9 out of 10 don't have a single resting, just says, upper partial. There's 5,000 periodontists in the United States, and every one of them tells me that 10% of the dentists do 90% of the crown lengthenings. What's your thoughts on that? Is crown lengthening, has the market spoken, it's really not necessary? Because some of these older dentists will tell you, well, if it invades the biological minimum width, it's going to do crown lengthening itself. It's going to be puffy and bleedy for a year, and then the bone will recede and it'll crown lengthen itself. Other people say that's crazy. What's your rant on that? Crown lengthening.
I'm glad you brought that up.
Really? That's the second time you said that.
I don't believe in osseous crown lengthening at all.
You what?
I don't believe in osseous crown lengthening at all. And the reason is that if I have, let's say, tooth number 4 needs osseous crown lengthening, I have to remove bone from 3 and 5 too in order to get a gentle ramp that's going to maintain itself. The problem with that is I'm compromising 2 more teeth to save that 1 tooth. If in the days of implants now, where we can do things so readily and easily and more predictably, why not just take that tooth out and put an implant in? And then I don't have to compromise the other 2 teeth. Why don't we, in some cases, orthodontically hyper up that tooth to bring up more root if the root is long enough, so that we can now basically get the ferrule we need to be able to put a restoration on it. So I really am not a big believer in osseous crown lengthening at all. And I think we're seeing less and less of that being done because of, implants being as predictable as they are.
Okay, my final question. Like I say, 9 out of 10 people email me, howard@dentaltown.com, about the show or whatever. They're just probably within 5 years out of school. Ryan and I just went and talked to the local dental student chapter last Saturday or Sunday. I want you to weigh in. I'm going to throw a bunch of questions at you, just give me your opinion. Some of them are scared. They got $300,000 to $400,000 in student loans. Some of them think that 25 years from now we'll all be working at McDentals. We'll all be working for corporate dentistry. They got $300,000 in student loans. They want to, when they grow up, they want to be just like you. They're asking, what direction they go. I mean, you got your AGD, your AAIP, your ACD, your ICOI. I mean, you got every damn Diplomat fellowship known to man. You are old enough to have a child walking out of dental school. What would you say to your own daughter if she walked out of dental school today with $350,000 and said, Dad, am I just going to be working for a chain? The golden years back in the 70s and 80s when you and Howard got out of school, or is dentistry, did I screw up becoming a dentist with $350,000? That's my question. Greg, did I screw up graduating dental school with $350,000 student loans? Where do I go now? I'm 25 years old.
I think the days of opening your own practice cold are long gone. I think that they're the best approaches, and I don't really think corporate dentistry is a good approach for the average dentist, because you're basically working in a mill where you have to crank things out as fast as possible, as much as possible. I think going and working as for somebody who's an associate, finding somebody, let's say, says, I want to retire in the next 5 to 6 years. I want to bring somebody in and over a period of time, get them up to speed and transition the practice so you're buying the practice over a period of time. I think that's an ideal situation. It's funny because a friend of mine's daughter she graduated a year ago. She wanted to go in oral surgery. He's a dentist. She wanted to go in oral surgery. She's doing a 1-year IV sedation residency. She got accepted into a Perio program. And I kept telling them, tell her to just be a general dentist. Send her to CE and let her do this stuff. These days, general dentists do so much. There's not a lot of reason to become a specialist anymore. General dentists are doing more endo, more ortho, more other procedures, implant placements than a lot of the specialists are. So why spend another 3 or 4 years or more money to become a specialist when you can take CE? The problem is you graduate with a $350,000 debt, you can't afford to take a lot of CE. So areas like Dental Town where you can pick up knowledge and it really doesn't cost you anything or cost you minimally is really the way to go. And when we graduated dental school, you and I, we had a license to practice dentistry. Well, things have changed, techniques, materials, everything has changed so much that you now, when you graduate, have a license to learn dentistry, because they can't teach you everything there is in dental school in those 4 years. You really have to take CE in order to really build up your knowledge base. And you also have to realize that, it's going to take a while to build up your speed and stuff, that you're not going to make a fortune when you get out of school. When I was teaching at Maryland, it was interesting. I talked to the seniors getting ready to graduate, and I said, what are you expecting? They said $90,000 a year, 4 weeks paid vacation. I went, what are you? You're not going to produce $90,000 worth of dentistry your first year. How are you going to get paid that? And you don't understand. You don't get paid vacation time. You're on a percentage of production. You take a day off or a week off, you're not making any money. So they don't understand that. When we graduated, at least when I graduated, you made like 40%, 35% of whatever you produced working for somebody. And at the end of the year, you had $35,000 you made, and you thought you were a king. They don't understand that. They figure, I'm a doctor now, I should be making big bucks. And they don't understand that things have changed. You have to really produce in order to be able to make any money. Well, I don't know if you were finding the same thing.
Well said. Well said. Greg, seriously, I've been to so many of your lectures, your courses. I've been your biggest fan for my entire career. I just want to thank you. You have 1,000 posts on Dental Town. Thank you so much for all that you've done for dentistry. Thank you so much for all that you've done for Dental Town. And thank you so much for spending an hour with me on Super Bowl Sunday.
Sounds great. Thank you for having me.
All right,
and don't forget the article next month on Perio Protect.
All right, fantastic. All right, take care. Bye-bye.
Bye-bye.